Please welcome Dr. Shmalberg.
Great. Well, thank you all, and I want to extend my thanks to the sponsors as well. And so initially when this talk was devised, I think Dr. Lewis was kind of looking at the sponsors that he had, and so we sort of combine these two things. But in many ways, the mechanisms of these two modalities, it makes a lot of sense to combine them together. And we'll talk about relatively, I hope, straightforward ways to dose laser, to think about hyperbaric veterinary medicine, what it is, what it can offer patients, and ultimately how we can use it in protocols, or if we should be using it. And so just to look briefly at some of the similarities. So this is a thermal image of a horse, so obviously infrared, and that's one of the things that we're predominantly interested in when it comes to looking at laser therapy. We're going to talk more about the specific wavelengths that are important and how this may be working, but technical difficulties. And then here, this is the only picture of oxygen. If you Google oxygen and try to find an actual picture, this apparently is published in Nature. So that's what oxygen looks like. Very exciting stuff. I know you guys are all very pumped about that. But the interesting thing is that both oxygen and laser therapy really is working on the mitochondria. And so for a long time we've asked the question, especially when it comes to laser, when is it appropriate to use it? There's a number of lasers on the market. What does it actually do? And now that we have hyperbaric oxygen chambers, which may be unfamiliar to many of you, we're asking the same question about what do we actually do with these particular therapies. Some of the applications that have been discussed for each are again similar. We can think about end-stage osteoarthritis. We can think about extensive wounds as seen here. This is a gopher tortoise, so it's endangered in Florida, and so we're treating it for this wound. We have pet possums in the great state of Florida as well, so this is a lesion, a non-healing wound on a possum. And then here, of course, we have the standard TPLO plate that we think about intervening with these two therapies going forward. But basically, when we think about laser, we're thinking about light. Obviously, the acronym for laser itself is going to be light amplification by stimulated emission of radiation. Very exciting stuff, but we know that laser, like all forms of light, is going to be electromagnetic radiation. What does that practically mean? Well, it means that we have particles of energy moving in a wave-like fashion. So the particle of energy that we're concerned about is ultimately the photon, right? So we have these photons transmitting themselves together in a wave-like propagation, and that's really what determines the amount of energy that we're dosing to a particular patient. You all are familiar, undoubtedly, with the different classes of lasers where we have basically them defined by their relative safety. So class 1 lasers are those in your DVD players or such that are still powerful, but they assume, unless you're maybe not the brightest, you're not going to take the cover off of the particular DVD player and look directly at the laser light. So really what we're interested in is the amount of potential damage that we can do to ocular tissues, to the retina. For medical purposes, we talk primarily, although there are class 1 lasers that are used clinically, we speak most of the time about class 3 and class 4 lasers. So class 3 lasers will be those that have generally about less than 1/2 watt in power, all right? And that, when we sort of do a striation based upon safety, we'll see that class 3 lasers can cause immediate eye damage, but really only if you're looking directly at the beam, which practically speaking, we don't commonly do when we're using therapeutic lasers. That contrasts to the much more powerful class 4 lasers, and we'll talk about the power and what that means for practical dosing. When we think about class 4 lasers, there's both a thermal damage to the tissue as possible, as well as damage from scatter. So this is where you see the laser safety goggles out. Those of you who may have class 4 lasers may have doggles for dogs that have basically laser safety in them. But those are potential risks when we talk about the higher power lasers. So this could be anywhere between 1/2 watt or greater.
Question?
Yep.
You said that the class 3, if you look at the laser, do you mean if you look at the laser or the beam goes into your eye?
The beam goes into your eye. So you're looking directly at the focal part of the laser.
So if you're doing a laser treatment and the beam's there, as long as you're seeing that, that's still not going to...
Yeah, scatter is a very low risk if it's indirect. So if it's bouncing off the patient back into your eye, it's very, very low risk. And that's why you'll see people they come with safety goggles, but many times they're not being used because of that low risk. Okay? And that's again how they're striated by their relative safety. One question that I was thinking about when I was first starting out using the laser was, well, we know laser is light and it's electromagnetic radiation. So why can't we just shave down a dog? This is one of my dogs that happens to be hairless. But why can't I just stick him outside? He'll get some electromagnetic radiation. I just don't have to buy a laser, right? So what about the laser itself is the critical factors that we're looking at for getting our medical effect. And you all, I'm sure, remember from physics, before, as a prereq, that we have EM across a spectrum. We have X-rays up here with relatively short wavelength, then we have longer wavelengths down here that are going to be radio waves, so on and so forth, microwaves. And then when we look at visible light, we know that that's most of what the sun's emitting. And here again, we have different colors, our different wavelengths. And then we have short wavelengths, which are the UV, and then we have infrared, which are going to have a slightly longer wavelength. All right? I'm really good with remembering the physics now. All right, so with sunlight, we have ultraviolet light, visible light, and infrared light. And those are the relative wavelengths we'll talk about. So this is what we're obviously seeing, and then many times our therapeutic lasers are employing the infrared spectra, which is going to be between 700 and 1,000 nanometers roughly. And it's this wavelength that's critical to determining both the degree of tissue penetration as well as the depth. So we know from a variety of studies that the shorter the wavelength, so the smaller the number, that it stays relatively superficial in tissue. Whereas if we get longer wavelengths, again within this spectrum here, we start to see it penetrate deeper into tissue. All right? And it's really the wavelength, irrespective of energy, that's going to help us to decide how far we can deliver those photons, which are going to have the biologic effect. And this is just for fun. Apparently, in the 20s, you used to order UV light generators to get a tan. It's probably not a great idea. But so again, we're using the infrared spectrum now, and not the UV or visible. So why does this wavelength matter? Did somebody just wake up and decide, well, I think 600 to 1,000 nanometers is where we should go? What's interesting is that we have these absorption spectra of different chemicals, different molecules, different tissues. We know, for instance, that water here has this absorption spectra. We have hemoglobin bound to oxygen with this spectra, so meaning up here it's absorbing a lot of energy. Down here, it's not absorbing very much at all. And then we have other things as well, like melanin in the skin, that are going to absorb some of our photons. All right? And ultimately, we're trying to get these photons into the mitochondria. And we'll talk in a second about what that's actually doing there. But our primary target, at least for most of our therapeutic lasers, is cytochrome C oxidase. And it absorbs photons somewhere in this therapeutic window, which you see is between 600 and 1,000 nanometers. So the reason why this is designed this way, we're just going to write off all sounds as, not being successful today. But so right here in this spectra, you see we have this sort of divot where we have low levels of some of these things that could interfere with our laser. So we can get it through hemoglobin, we can get it through water without it being absorbed. And melanin, it's sort of consistent across this wavelength. So this is the reason by which we have therapeutic lasers within this category. What are some terms? If we talk about the laser, we have to first establish that, of course, many of the lasers that you buy or use, they'll talk about different things. Photons, we've already discussed, are really the unit of light energy. And then other laser companies will talk about the spatial coherence of their laser and their temporal coherence of their laser. So spatial coherence, as the name would imply, just basically means that we have things sticking together. So we've got these photons, and they're not going to scatter out, they're going to stick within the same relative spectra. And then temporal coherence means they have a similar frequency or wavelength. So that's what we want. We want the same frequency, the same... think that's better. So with power, when we talk about the power of a laser, you all have understood that that's really the wattage of the laser that we're designing. And so that's going to determine the amount of energy we can deliver, which is joule, named after this fellow here with the great beard, per second, all right? The amount of energy, or the number of photons we're going to deliver per second. Energy, on the other hand, expressed as joules, is you take the watts, all right, so the power of the laser times the number of seconds. Clear? What's confusing is obviously what this laser is actually doing. So we all like it, you can obviously charge for it, we think it's increasing tissue healing, but what we find is we have this fibroblast here, just as an example. We apply photons to the tissue. They hopefully, if they're in the right spectra, enter the mitochondria, enter the cytochrome C oxidase complex, and then ultimately help to generate and drive this proton gradient over the mitochondrial membrane that ultimately generates ATP. So it gives us cellular energy. Now that energy can be used for tissue repair, protein synthesis, etc. We also see at the same time that we have oxygen being released from tissues and liberated, and that's creating oxygen radicals. All right, so free radicals, free relative oxygen species, etc. Now these you would think, oh, free radicals are bad, right? We try to avoid free radicals, we take antioxidants. What's increasingly clear, and this will be true with hyperbaric as well, is if you have low levels of oxidative species, of oxidants, it actually increases cellular antioxidant production. And that cellular antioxidant production persists for several days after the particular treatment. So we're seeing this short-term oxidative stress that doesn't cause any cellular damage, and then we're basically seeing that we get antioxidants that have increased over time. We also see nitric oxide being liberated, and that's responsible, in addition to the heat that's created by the laser, for vasodilation at the site. And of course, vasodilation, we have increased blood flow, increased tissue factors able to hopefully regenerate the tissue. The controversy has been, how exactly do we dose light? So many of you that have lasers, some of them will be pre-programmed with settings, right? You're like, okay, small dot, I got this, stifle, and you're going to go through the motions. A lot of the controversy about lasers is not whether or not it works, but at what dose you apply it. So there's something called the Arndt-Schultz curve, which basically is a hypothesis that for any given therapy, and in this case the laser, you have a window here where you have a stimulatory effect. All right, so you have an optimal dose of laser, of energy, of photons that you're delivering to the tissue. If you deliver too much, however, you could get an inhibitory effect. When we think about that in the case of laser, if we deliver too much heat, too many photons, too many oxidative species, we can actually get cellular damage or death, which is clearly not the intention if we're aiming for tissue healing. So this is the focus of all the debate amongst the companies and in the scientific literature. And this is really the arc that we're searching for in laser research. So how should we be dosing the laser? If you think about this objectively, we should really be dosing according to energy, not according to the power of the laser, right? Because we're delivering photons. The photons are a unit of energy. It's the photons which exert the biochemical effect. And so that's equivalent to the amount of joules per area that you deliver, or the power of your laser times the number of seconds you use it, divided again by the area. And you're saying now, well, that seems impractical. There seems like a lot of math going on there. And really that is to some degree true, which is why there's these presettings on the laser that you may have or that you're thinking about buying. And for the most part, the recommendation has been to deliver around 5 joules per centimeter squared of tissue. All right? Now that's at the site of the actual injury. So if we have a deep tissue, that's 5 joules at the site, and we're going through more pigment, we're going through more water, and so we have to make adjustments for that. So what adjustments do we make? No one has any idea. If they tell you they have an idea, I'm somewhat skeptical, because the literature is all over the map in terms of what exactly you should define your ideal dose for a particular tissue. So to add to all of the guessing, I've created my own guess. So looking at some of the physics of laser, the way that we've standardized laser in our practice so we can figure out with consistency applying laser to the same to all patients, so we can do retrospective studies, is to use this equation, which uses some physics, but again, at the end of the day, it's simply something we're doing to try to standardize it based upon the best evidence that we have. So we take the 5 joules per centimeter squared, we roughly estimate how many square centimeters of the site we're treating, and then we apply some sort of a constant here, which I call K for fun. And that constant takes into account, and this is in your proceedings, how deep the tissue is. The deeper the tissue, the more photons we need, because we have to ensure that most of those photons get to the site of injury. And then with hair coat, the more hair coat they have, the more pigment they have, the more melanin is going to absorb some of those photons. So it is true in humans as well as in animals that if you have dark-skinned or dark-pigmented individuals, you need to deliver a higher laser dose than if they're white animals, all right? And you also have more of a risk for thermal injury for black dogs. Some of you that have used class 4 lasers may, or we have our students sometimes do laser and will, smell burning hair. And so that's actually because too many photons in the black tissue, and it's actually causing thermal damage to the tissue. So we have to be somewhat cautious of that. But this is the general approach that we're using. So now you all are buying lasers or have lasers that are based upon power, right? So you're making some recommendations about this. And so I wanted to use this example of a stifle and a Labrador. Here's what I've estimated. I've not actually measured this size. And then I've applied this constant. And I've found that I need to deliver about 2,000 joules if I'm going to treat both the joint and the periarticular tissues as well. Okay? And so if we now use a class 4 laser that has a relatively high power, say we set it to 5 watts to avoid singeing the fur, then it will take us 7.5 minutes to deliver that dose of photons that we've calculated. All right, 7.5 minutes, that seems doable. Now if, however, we have a class 3 laser and we want to treat that entire range at the same recommended dose, it's going to take 10 times as long because it's a 0.5 watt laser. All right? So that means it's 75 minutes to deliver that same amount of dose, the same number of photons. So the power of the laser, the class 3 to class 4, really is determining the number of photons and therefore your treatment time. Now what some people will say with the class 3 laser is, well, you really don't need to treat all of those periarticular tissues, those soft tissues. You can just go, in what I call the peripatellar window next to the patellar tendon, try to get photons into the joint, and there you have a much smaller surface area. And so therefore, if you only need 30 joules, it would take about a minute with a class 3 laser, okay? And so this is the critical factor, is that we're dosing based upon joules, but the wattage is determining the length of time we have. So a class 4 laser is not necessarily better than a class 3. It just depends upon what you're trying to achieve. And unfortunately, and naturally so, every company's laser is different. So the studies that are done with one laser cannot be extrapolated to studies with another laser. This is one of the fundamental challenges we have in veterinary medicine, is deciding which laser to use. Because at the moment, you could really probably go with any of them, because they all tend to have wavelengths within that therapeutic window we talked about. Some will have a fixed wavelength and only one. Some, like this companion laser, will split the energy, the wattage, into 2 different wavelengths. And then now there's lasers where you can actually set the wavelength. And so if you have a small number, that might be for superficial tissue, and a large number would be for deep tissue. And each of these companies, of course, thinks that their particular wavelength is the best, and there's some literature to support that. But at the end of the day, we really, for each laser, you sort of pick the one that's going to give you the most features, and you're looking at the amount of time savings between class 4 lasers and class 3 lasers. So what's actually the evidence? Well, clearly in the veterinary literature, we still don't have strong evidence in randomized controlled trials. We're relying to some degree on that evidence which exists in people and in laboratory animals, in which we found that there certainly has been reductions in skin healing time, increases in collagen synthesis, reductions in pain, decrease in inflammatory mediators. But in the veterinary literature, if you ask me and you ask 10 other people, you'll probably get 11 different answers on the best laser, the best wavelength, and so forth. We have one study that was done at UF that was a randomized controlled clinical trial looking at a class 3 laser and basically trying to determine why or how the animals were ambulating, how long it took for them to ambulate. And they found that with class 3 laser therapy, for 3 consecutive sessions daily, they had a median time to ambulation of 3.5 days. In the group that was controlled, that did not get laser, they had a time of 14 days. One of the confounding variables in this study, though, was we were doing rehab as well on some of these animals, all right? So we have all this clinical data where patients might have been treated differently. But this was statistically significant and suggestive that at least this laser and wavelength decreased the time to ambulation after intervertebral disc surgery. So it's these features of the laser where we basically have them working at the same wavelength within this therapeutic window that's critical. We know that we need more controlled studies, and unfortunately, unless you set a dog outside all day long, you're not going to get enough energy from the sun. But if you have outdoor dogs, you shave them down, it's theoretically possible they may actually get therapeutic benefit from sunlight because there's enough energy at the therapeutic window. So, but we can't charge for that, I don't think. Unless it's during boarding and then at your kennel, you know, you could say you did sunlight therapy for some degree of time. And so I wanted to certainly talk about laser and how it relates in addition to hyperbaric oxygen. We're one of the few veterinary academic institutions, I think still the only one, with a hyperbaric chamber. And we know that oxygen has been used for all sorts of things. This is after a binger at a concert. This is obviously in the South, as you can tell. Oxygen has been used for these as nasal oxygen bars. Anybody have these in their towns? This was the late 90s, I think, where these were all the rage. And then in Houston, you can call the oxygen girls. You can get hooked up with some oxygen as well. But we think about oxygen having these potential benefits that are touted, and these are obviously crazy examples. But in Japan, they also have oxygen bars for dogs, where they put their dog in a little oxygen chamber, and they report that they have a lot of increased energy afterwards. But when we talk about medical oxygen, you know, we want to have it a little bit better than what's going on at these parties. There's a long history of hyperbaric medicine and hyperbaric oxygenation dating back to the 1600s. And it was used, of course, for the bends and divers at the Brooklyn Bridge, and it's still used for the bends, the primary treatment to this day. And then we've seen relatively large academic centers start using hyperbaric oxygen throughout the course of sort of medical practice from the 70s on, at least in the human field. This is a picture of what used to be a hyperbaric hotel. So they actually had people in the 20s that would go there, and the whole hotel was basically pressurized with oxygen, and they had to have a robust sprinkler system because people would refuse to stop smoking in the hyperbaric chamber, and so they'd have to douse themselves with water. But so there is that spark risk. But what we're trying to do with this medical oxygen is really affect the oxygen cascade. And so when we think about the oxygen cascade, there's this therapeutic phenomenon by which we see oxygen diffuse down a tissue gradient. We have inspired oxygen and alveolar oxygen at a lower gradient, arterial, and so on. And so it's moving down from inspired oxygen, I don't know why this is doing this, technical difficulties, but moving down to mitochondrial oxygen as well. Okay? And so what we're trying to do is affect the arterial oxygen content by pressurizing. And that's based upon some basic principles about oxygenation. We know that our arterial oxygen content is determined by the amount of hemoglobin, which usually we can't affect unless we do a transfusion. The saturation of hemoglobin, which most of the time is near 100%, or the partial pressure, at least the arterial pressure of oxygen. So this is something that we can affect even in cases where we can't do anything about these two, where we sort of have a normal PCV and a normal pulse ox. We can increase the pressure based upon work done by Henry, who everyone again will remember from physics, who stated that the concentration of a gas in fluid is directly proportional to the pressure. So if we pressurize the patient, there's more oxygen that's delivered to the tissues, more oxygen in arterial circulation. All right? There's another medical sort of law or physics law by which Fick told us that when you have a semi-permeable membrane like we have in anoxic or hypoxic wounds, we actually can increase the diffusion distance of oxygen. Many of those that do a lot of surgery have seen hypoxic wounds that ultimately fail because of lack of oxygen. What Fick's law is, the reason it's irrelevant to hyperbaric oxygen is we can deliver oxygen even in the absence of a blood supply. All right? So if we have no blood supply, we can have interstitial fluid, we can get oxygen to migrate across, and that can preserve the wound while we get angiogenesis naturally occurring. So it may extend the time that we have where we maintain wound viability. And so the physiologic effects of hyperbaric oxygen are basically we increase pressure in the oxygen cascade, and it's this oxygen content in the mitochondria that's normally limiting to oxidative phosphorylation. There's actually been studies done where pigs can survive with a PCV of 0 in a hyperbaric oxygen chamber. At 3 atmospheres absolute of hyperbaric oxygen, you no longer need red blood cells to carry oxygen. So this is an extreme example of how well we can deliver oxygen if we pressurize the patient and deliver it in that sort of a fashion. And of course, we have decreased tissue hypoxia as well. So here's a schematic of what's happening with the hyperbaric oxygen. We see increased amount of oxygen moving into the cell, which therefore moves down the diffusion gradient into the mitochondria and increases our ATP production, much like the laser. We also see, understandably, an increase in free oxygen radicals. These are sublethal amounts to the cell, and these upregulate endogenous antioxidants, which we think have a favorable effect on tissue survival moving forward for the months, the days after a treatment. And then we also see liberation of nitric oxide, and that causes vasodilation following the potential treatment with hyperbaric. There's been other studies in a variety of models that have shown that we can increase growth factors, so platelet-derived growth factor. Those of you using ACP will be relying on this sort of mechanism. It's also been shown in humans and in laboratory animals to increase that. Fibroblast growth factor, vascular endothelial growth factor, those are both things of interest when we talk about laser as well. And this increase in antioxidants as a result of our increase in free oxygen radicals. HIF1 basically is upregulated with tissue hypoxia and can be favorable in these particular cases where we have tissue anoxia following surgery or tissue damage or impaired tendon healing. And ultimately, at the end of the day, we get increased tissue oxygenation. So what about potential side effects? One of the things that's discussed most commonly is oxygen toxicity. So oxygen toxicity has been reported in the diving literature whereby animals experience seizures when they get an overdose of oxygen. The mechanism by which that occurs is unclear. When we use hyperbaric oxygen in people, there's about a 0.04% chance that they'll develop a seizure in a hyperbaric chamber. At UF, based upon our initial studies that we're doing, we have a rate of about 0.5%. We've since modified our treatment protocol and we're seeing much lower rates of oxygen toxicity. And then the frequency and duration of treatment also affects the potential for oxygen toxicity as well as our dose. It tends to take about 45 minutes in a hyperbaric oxygen chamber to get biologic effects. And so we're ultimately using about that time frame at UF. A total treatment takes us about 1 hour and 15 minutes. We've had to sedate 1 dog out of 600 treatment sessions that we've done, so generally it's very well tolerated. In people, there are reports of barotrauma. So the depth that we're taking these dogs when we pressurize the oxygen is about equivalent to 33 to 66 feet below water. So that's the pressure they're going to feel on their ears. We've put all species in there, from birds to reptiles to primates to dogs and cats, and we've not seen any barotrauma. Usually dogs will, or cats will, yawn instinctively at about 15 feet of pressure, which is somewhat interesting. We have seen reversible cataracts in a water-skiing squirrel that we treated. Yes, I said water-skiing squirrel, this is Florida. But that's reported in humans as well, reversible cataracts. It's not been reported for small animals, but perhaps you need to be careful if you get a hyperbaric chamber and you treat squirrels. Just a caveat. So I'm sure that's the take-home message everyone will look for. So what about the veterinary-specific literature here? There was some work done in horses, and the equine chambers are seen here, where you actually walk the horse into the chamber, much larger than the small animal chambers that have been developed. And they found that in equine endotoxemia, they had an increased clinical score, meaning they fared better when they treated them with hyperbaric oxygen, but it didn't change their biochemical abnormalities, at least at the treatment that they selected. With equine mesh skin grafts, it increased the inflammation, and so that's obviously something we don't want to have happen, but mesh skin grafts are somewhat controversial, and so it may not be the best model. And then much of the veterinary work in laboratory settings was done in cats, surprisingly. And these were laboratory cats that had a variety of procedures, and we saw increased bone formation in cats with feline bone grafts, basically, or cats with bone grafts. And no radiographic difference, though. So histologically, there was a change, but it couldn't be appreciated on rads. And then for skin flaps, where we've also used hyperbaric oxygen in combination with the surgeons, they reported decreased exudate and increased color to those flaps, but that was not statistically significant. As with laser, then, we're relying primarily on the human literature. It's very well established that we can treat decompression sickness or the bends and divers. We have relatively few scuba diving dogs and cats, although there are some. So probably not an issue in veterinary medicine. Carbon monoxide toxicity we've seen a couple times at UF, and it's universally established that hyperbaric oxygen decreases the half-life of carbon monoxide, which decreases the respiratory effects. And then there's a large degree of evidence supporting extensive wounds like diabetic foot ulcers, osteoradionecrosis prevention. We've been using that in combination with the oncology in some preliminary studies and are having favorable results, but not yet published. Extensive wounds or burns, osteomyelitis. We've treated some performance animals for that, and then vascular injury as well. Experimentally in the literature, and this is perhaps most relevant to sports medicine, is that we see differential changes in the type of collagen and tendon and ligament injury, where we actually see increased strength of a tendon rupture or tendon repair following an experimental surgery. In this case, we've seen increased tendon healing in rats. There's a lot of work that's been done in spinal cord compression, suggesting that hyperbaric oxygen improves time to ambulation and decreases things associated with chronic spinal inflammation. And then this is the literature we're sort of delving into now and working on at UF, which is, can hyperbaric affect chronic or neuropathic pain? And so this is out of literature in rats and in people, where they report for chronic pain conditions associated with osteoarthritis, with chronic injuries, that we're seeing decreased pain signaling. This is actually here, this was a study where they looked at the brain of rats and something, a protein called CFOS, which is associated with chronic pain stimuli. And you see here we have basically the control group, and then here you basically have them after a particular tissue injury or induction of chronic pain. And this is an induction of chronic pain plus hyperbaric oxygen. So just a histologic examination of one of the proteins that's helpful in understanding chronic pain. And then there's also been studies in rats as well as humans showing reduction in pain as measured either with force plates or, in the case of people, with analog scoring. And those have all sorts of issues related to owner or human bias, but nevertheless, that literature is coming out. So I wanted to discuss a couple of cases where we've used both laser and hyperbaric oxygen. This is a dog where you can clearly see some cerebellar hemorrhage here, or some sort of vascular compromise. I guess we can't say definitively it's hemorrhage, but the CSF was consistent with that. And so this dog displayed all the signs of a cerebellar infarct. It was a dog that the owner was very interested in regaining performance. So this is what we'd expect with cerebellar disease. So obviously head tilt, unable to ambulate. It presented to UF for further evaluation, and we also discovered incidentally, by not being able to get a Doppler pulse on this dog, that it had a large arterial clot in its axillary artery. And you see it's occluding about 75% of the flow, and we were starting to see tissue compromise in the leg. So clearly this dog was having multiple thromboembolic events. We decided, both because of the potential for tissue hypoxia in the leg, as well as the cerebellum, to intervene with hyperbaric oxygen. This is shortly after we had the device available to us. We treated at what would be equivalent to 33 feet underwater, using 100% oxygen. We treated for 45 minutes daily for 10 consecutive sessions. Following 2 sessions, we saw improvement of neurologic signs, and then now you can see this left 4 is the one affected with the axillary artery clot. And so we did additional sessions as well, and the dog eventually regained function there. We also applied laser therapy distally on this left 4 to try to provide another route of stimulating ATP production and tissue regeneration in case there was damage. Now the confounding variable, as is true with all rehab cases, is of course we did everything else we thought might be helpful, and that was the wish of the owner. So we did electroacupuncture, certainly daily, and then we also did standard rehabilitative techniques, proprioceptive retraining. And so at the end of the day, it becomes difficult to say which of these, or the combination, was ultimately responsible, or was it natural improvement. But this is certainly the type of case in which we're thinking about tissue hypoxia and massive inflammatory response, where we're trying to intervene with some of these tissues. So we've had a couple of performance animals in Florida that have gone out and in the course of, this was in the course of lure coursing, got bit by a moccasin. And so obviously that's a little bit of a performance impairment, not a classic thing we think about. But we get referred many of these snake bites first for laser therapy, where we're seeing some measured decrease perhaps in tissue swelling. But the surgeons were very well convinced that they were going to have to debride the area down here, which ultimately looked very necrotic. So instead we elected to do 3 daily hyperbaric oxygen sessions in combination with laser, as I dosed previously, and this is what we were left with at the end of those 3 sessions. All right. So the surgeons claimed there was still tissue necrosis right here where the fangs went in, and so they weren't going to give me any credit. That's how surgeons are. But nevertheless, you know, still what we thought was a measured improvement. We've looked at rattlesnake envenomation as well, and this was a dog that was out fielding and had massive amount of tissue swelling, and we see about, with hyperbaric oxygen, about a 20% reduction in facial swelling as measured with circumference immediately after a hyperbaric session. And then to some, yes?
So on that first session, could you have argued back to them that don't bring a knife to a laser fight?
Well, I think the surgeons, they were just preparing to cut it. They like to plan and prepare, so they were going to cut it right away. But they said, you know, once it's a horrible disaster, we think we're going to have to go in and cut this. And so that was the wager that we had. I had really no evidence hyperbaric and laser was going to help this much, but I always like to give the surgeons a hard time. And so this seemed like a good example. If it didn't work, I have nothing to lose because they expect rehab to not work as successfully as some other things. So, and the same is true in some of these cases. And we're hoping to have a randomized controlled trial going where some of these dogs will get hyperbaric oxygen laser and some will not, so that we can better have stronger scientific data supporting that. We've had other cases, especially of cervical pathology. This is a wobbler, no surprise there, that basically they did a distraction fusion on the neurologist. It did fracture, obviously, the repair, but it was still at least dynamically stable. And what we saw though is after the surgery, as sometimes happened, the dog was worse. So it was ambulatory tetraparetic coming in, and then it was non-ambulatory tetraparetic after surgery. And anytime something worsens, that's usually a surgeon indication for rehab, even in most normal practices, right? It's, oh, we got to do something about this because I may have made it worse. And so this was a dog that also got a thermal injury over its lumbar region or pressure necrosis or something. And so then they were really worried because, oh, now we've got to go cut this out, and it's necrotic, it's going to be a disaster, the dog's worse. And so left with no other options, they sought our counsel. And we ended up doing hyperbaric and laser for this dog. And there's of course controversies about whether or not laser can penetrate the spinal cord. But so we treated this dog, and after a few days we saw measured improvements in his clinical signs. Again, how much of that might have been naturally occurring, but the surgeons were convinced, at least with this necrotic lesion, they were going to have to debride it again and take off tissue, and we did no debridement. It formed a little bit of an eschar, and then underneath, perfectly healthy granulation tissue with no surgery required. So the owners and the surgeons were pleased at that outcome. This is a non-surgically repaired 1 kilo Chihuahua that actually arrested, and the owner did mouth to snout, or whatever you call it, resuscitation, brought it back at the hospital. It was placed on the ventilator. And after that, the owners were not really inclined to put this dog under an anesthetic procedure. Since we just had it on the vent, we finally got it awake. And as a result, they elected to pursue just standard rehabilitative techniques. And here you can see the compression here at C2, C3. And the neurologist had a fairly poor prognosis for this dog. When we looked at it, basically it had no coordinated motor whatsoever, mentally inappropriate after the arrest, as many of them are, even when it came off the ventilator. And initially, basically, after about 5 days, this is the best that we got. You see it's severely kyphotic, and it would stand. So that was an achievement. And of course, the ECC folks were like, your dog can stand, game over, we're done. See, this is perfect. But the owners were like, well, I'd like a little bit more than standing. I know this dog's not going to be perfect, but can he at least go outside, urinate, and defecate? And so this dog is admittedly a disaster. It also had bilateral grade 3 luxating patellas, but we did rehab as well as hyperbaric and laser on this dog, and so it stayed with us for about 10 days, and the owner was very pleased because this is nowhere near normal for any of those that have any doubt. But she's maintained this. It's been about 1.5 years now. She comes in about every 2 months for a single hyperbaric and laser when she starts to notice a decline in function. I have no idea if it's actually the cause, but she says afterwards it goes back to this state. And so she's very pleased in what's going on and the fact that we don't have to do surgery and the dog's ambulatory. Now, of course, I'd love to show you a perfect case where that Chihuahua is normal, but it's a Chihuahua, so you have to give it a little bit of a break in that instance. Other things that we're working with laser and hyperbaric are severe osteoarthritis. So this is obviously severe degenerative joint disease in an elbow, and we do a lot of intra-articular morphine therapy, actually, which is published in People, and we tend to get several weeks or months of response, and we use that in cases where we don't want to inject steroids. And in some of the human literature, morphine seems to be as advantageous as triamcinolone. So this is, again, something we're experimenting with, but in this particular patient, we went through ACP, morphine injections, we did do steroids, local anesthetics. We injected everything in the joint we could think of, which probably caused some tissue trauma itself. And we got mild improvement, but really not enough. And at the same time, we are, of course, doing strength building, trying to increase muscle mass. This dog was muscle wasted when we saw it. And surprisingly enough, after all of this rigmarole, the dog still is doing quite well. And we're now only relying on this protocol. It gets laser twice a week using a class 4 laser dosed according to the rubric I gave you. And then hyperbaric oxygen we're doing once a week at 2 ATA for 45 minutes. I think we're running low on time, but it's not all about dogs and cats, even though this is a canine symposium. So we get asked to rehab as well most of ZooMed's animals, and we're trying to push the envelope a little bit in terms of active rehab for these species. This is a barred owl that had a radius ulna fracture, that had an X-fix, and then developed wing droop. So here's our idea of active exercises in an owl, which is somewhat interesting most of the time. And then we also had this callus that went through these tendons here. And so this is another case where we actually use hyperbaric, laser, and therapeutic ultrasound, and ultimately this owl was released, so this was a wild owl. Whereas historically with this type of fixator, we've seen that they've been non-releasable. And we've since done several additional raptors using sort of rehab protocols that were modified from other species. And then this is just a final case. This is actually Pythium. And in this owner, the owner elected not to do surgery because of its location on the face. And we now have a research program in vitro looking at Pythium. And we did a combination of an experimental drug and hyperbaric oxygen. And this is over the course of about a month. We're now 7 months out. And you can see as the photos go along, we saw progressive improvement of the lesions itself using laser and hyperbaric. And this was a dog that the owner was obviously very invested in. This is what the dog looks now. And we have no recurrence of the disease after 6 months. So we're still monitoring this. It's too early to say if this is a viable treatment for Pythium, but we're doing laboratory studies right now, trying to sort this out. It's one of the areas where we see more and more. We have 6 cases right now, 3 of which are fielding dogs with cutaneous Pythium that we're treating with this combination instead of surgery, trying to look at the differences. If you have any questions, I'm happy to entertain them.
Osteoarthritis case where you said you're treating it with laser a couple times a week.
Yeah.
And you're looking at being able to ease back on that, or is that going to be basically a permanent schedule on this dog?
We have found, and again, sorry. So the question is about the clinical case with laser and hyperbaric oxygen. Has there been any attempt with the laser to back off on the laser therapy? The answer to that is we have tried to back off, and we've modified different things. And for whatever reason, this protocol in this dog seems to be helpful. And so if we go less than that, the owner at least claims that at home, we see measured differences. Now this dog has severe osteoarthritis, so when we look at joint angles and other objective measures that we have clinically, it's a little less clear. So we're relying on owner observation, but it is an important question, and historically we would of course try. The owner's quite happy with this protocol. Yes, sir.
Are you using airbags for your protocol?
So, yeah, the question is about the ascent to descent when we're pressurizing a patient. Oh, during the protocol itself. No, so during the protocol itself, we're not. So we're bringing up the pressure, we do a fixed pressure, and then we descend afterwards. Generally, we've now standardized everything to 2 ATA, so that when we do retrospectives, we can go back. Other people are doing anything from 1.5 ATA, of course, up to 3 ATA. But we're trying to pick a standardized protocol, at least in the beginning, as we develop clinical experience, so we can see what's what. Yeah. Yes.
Why did you pick the timing of your protocol? Did you have some data that told you, like for the laser, you were doing once a day while they were in the hospital? Some of the hyperbaric chamber you were doing 2 times a week. Do you have anything, or was that you just had to start somewhere?
So I think the question is about the frequency of hyperbaric oxygen and laser. What I'd say is for any given condition, there usually is some experimental research in other species about the frequency that's been reported when clinical improvement has been measured. So to give you an honest assessment, our clinical experience is only a year with hyperbaric oxygen, longer with laser. But we tend, for every given case, if it's a new problem we haven't encountered, we go to the basic science research that's been done and look at their protocols, because we just don't have a sufficient number of studies yet for me to say, this protocol is the best protocol. So we're making clinical judgments based upon the literature we have, which admittedly needs to be better, and we hope to contribute to that.
I think if there's any more questions, maybe you can.
Yeah, I'll take them out after. No problem.
Thank you very much.